Welcome to Between the Sheets, the podcast where we're going to cover a variety of topics related to sexual health and wellness. I'm Dr. Stephanie Zwonitzer, your host. I'm a nurse practitioner and have been in practice since 2017. I have my Doctor of Nursing Practice degree, and I specialize in urology and sexual health. I am so excited to explore all of the various topics related to sexual health and wellness with you in a fun, spicy, educational, and non-judgmental manner. So come on, let's get between the sheets. Hey, welcome back to Between the Sheets. I am Stephanie, your host, as always, and I have a guest here today, Scott Christensen. He and I met at a sex conference in last year, and so we have this great opportunity to get back together today and talk through some things. Scott Christensen is a nurse practitioner who has been in urology for 11 years. In a prior life, he was a critical care nurse working in the ICU, ER, and trauma. Then the field of urology came calling and he embraced the change head on. Scott was recruited out of his NP program to join Urology San Antonio to help open the Men's Health and Wellness Center. This is where he runs stronger today than it ever has been. Although he treats general urology, he specializes in ED, low testosterone, Peyronie's disease, and male infertility. Scott is a frequent speaker in forums in men's health, namely ED, Peyronie's, and low T, and is also published on the subject of low testosterone. When Scott isn't busy trying to save all the penises, he enjoys all of them. He enjoys a good pickleball match and a lousy game of golf. When asked how Scott made his journey from critical care to urology, he always quotes Tupac Shakur, "I didn't choose the thug life, but the thug life chose me." Welcome, Scott.
Thanks for having me.
Yeah.
You know, it's so funny in that intro, you totally forgot to mention I'm slightly immature and I'm prone to giggling, so that might come across also.
I think all of us in urology are.
And I love how you're like, oh yeah, we met at a sex conference. I'm like, whoa. We might need to rephrase that a little bit.
It was a professional conference, the North America Society of Sexual Medicine.
Right.
It was not a interactive.
Right.
Meeting.
That was our second meeting. Was at the other sex conference.
Scott, it's so good to have you here today.
No,
and
thanks
I know
for having
that
me.
you specialize in men's health, as do I, but I also see the women as well. For me, it's always good to talk through some of these men's health issues with another provider. Certainly, we have other providers listening today, but we also have, non-medical people who we can really help get to the right place and get the help that they need, maybe start some steps before they even come and see us. So let's start with erectile dysfunction.
Okay, well, actually, before that, I just wanted to address a few things. I don't know who did the cover art for your podcast, but I noticed how you had a few little lady flowers in there, and I absolutely love that.
Yeah, there's some lady flowers and some penises in there. Yep,
I love it. Yeah, and then also, like, as I was trying to prep for this podcast, I was listening to some of your other podcasts. You've had some amazing guests, by the way. First and foremost, I want to talk about Gabby Salas. That girl makes me want to meet romantic smut.
Yes, isn't she fantastic?
Yes. So Gabby, if you're listening, you reach out to me. You and I need to be besties. And then, of course, and then next is Angela Griffiths, the Christian sexpert. Yep. That girl is amazing. And seriously, who doesn't love glitter, right? I mean, I love glitter also.
Yeah,
absolutely. And then lastly, the expert of them all, Ken Mitchell. You can't beat that guy. He's got so much knowledge. I laugh that you even have me as a guest. Ken can do everything and answer all your questions. But thanks for having me.
Yeah, absolutely. Yeah, Ken is great. He's, a colleague of both of ours. We both respect him a lot. So I was excited to have him on as well. But you are an expert as well. Just because neither of us have been the APP of the year doesn't mean we're not good at what we do.
Yeah. Well, 11 years and I still feel like the new kid on the block. But we're learning, right?
Yeah, there's always room to learn and to grow. Yeah, absolutely. So when you have guys come see you for erectile dysfunction, talk to me about what are they first coming in for? What are they describing to you that they have going on?
Well, that's actually a pretty open-ended question. So let's just take the general person, just the general new patient, ED. I want to ask questions. I'm like, well, tell me about your erections. Are you able to get an erection? If you can get an erection, can you maintain it? Can you hold it? So there's just a flurry of questions. So Let's just say, yeah, I can get an erection, but it's not the strongest. Or I can get an erection, but I lose it very quickly, especially if, like, depending on what position I'm in. Can I get an erection with intercourse versus masturbation? Again, there's so many different questions. So as always, it starts with the provider's history and physical. So I just want to know more about it. I also look at all the medication list. I want to see what medications they're on. I like to know a good detailed history. Most erectile dysfunction is, it's a matter of blood flow. It's funny. It gives me a great opportunity to mention my mentor, my love and true. His name is Dr. Leroy Jones. That guy trained me 11 years ago. He's the one who recruited me into urology.
Nice.
And pretty much taught me everything I know. But it's so funny. We used to see urologic residents all the time. And I would just watch him grill these guys left and right. And he would be like, one of the first questions he'd be like is, well, tell me what are some of the risk factors for erectile dysfunction? The resident would sit there and kind of think. They're like, well, and they kind of throw a flurry of questions or flurry of answers at him. He goes, just stop right there. It goes, what are the big risk factors for cardiovascular disease? And the resident immediately, high blood pressure, high cholesterol, diabetes. They just spit them off right there. And then it goes, there you go.
That's it.
Those are the big risk factors for ED. It's a cardiovascular issue. No flow, no grow.
Yep.
And
absolutely.
so I always thought that was funny.
Yeah, that's a good one.
But yeah, so once you get a detailed history, and if they haven't really tried any medications, then might try them on a PD5, tadalafil, sildenafil, or Cialis versus Viagra. We all know the names.
Yep.
I typically prefer Cialis myself. I think it's a little bit more gentle on the body. It's a little longer acting. You don't really have to plan as much for it.
Yeah, I like the spontaneity it gives.
Yeah, it kicks in much quicker than Viagra, and of course, the way I refer it to my patients, I call it the weekend pill. You take it on a Friday, it's going to be in your system Friday, Saturday, and Sunday.
Yep.
So less prepping, more enjoyability.
Yep. And I always say, you never know when you're going to fight. So you take this pill, and then all of a sudden you end up having an argument, and you can't have sex tonight. Tomorrow morning, you don't have to pop a new pill. You can just make up.
What relationships have you been in? That's a good example.
Each their own.
Yeah, exactly. Exactly. Well, yeah. But then, of course, then you have the Viagra or sildenafil. Of course, it's out of your system for 4 hours. You really got to plan for it. You got to take it 45 minutes to an hour prior to, as close to an empty stomach. So, and I feel like it's a little bit harder on the body. I feel like most of my patients have more side effects with it than they do the Cialis. Namely the headache, the blurred vision, backache, that kind of thing. So, but I tend to skedaddle a little bit more towards the Cialis than I do Viagra.
Yeah, I would say that's generally my practice as well. Sometimes I'll start with the Viagra just if they're like super naive to medicine and they have no idea whether or not they're going to get side effects, only because it'll be out of their system faster.
Yeah.
But I do agree with you that they tend to have stronger side effects with the Viagra than the Cialis. Yeah.
Now, I mean, and that's kind of the answer to your question, though. That's how my initial workup is. Now, obviously, if these guys have a complicated history, if they are diabetic, if they do have high blood pressure, if they're taking, a buttload of medications, then, it's a little bit trickier to pick what kind of treatment options I have for them. I mean, I typically tell my patients, let's just take the regular guy off the street, not on any medications, no comorbidities, relatively healthy, but starting to have some ED.
Yeah.
Whenever you take the pills, the PD5 inhibitors, they're only responsive in 60% of the population. That's even people who don't have any comorbidities. So there's still that 40% that they may not even work on.
Right.
But I mean, it's always a good option. And the algorithm as well as I do. If the pills don't work, then injections and implant, all the other stuff.
Right.
But, we're still talking about the no-vu patient, the brand new patient.
Right.
And if I do have a guy who's never seen anybody, hadn't had any kind of workup, I'll order some labs. Of course, I'll check a testosterone level, lipid panel, an A1C if he's never been worked up. Those are always the big risk factors. I'll even check a TSH as well.
Yep. Yeah, for sure. And, I think it was so interesting to me when I first got into urology and was learning the ins and outs of ED, just how important that cardiovascular piece is.
Oh, for sure.
I mean, it can even be a predictor of if you're going to have a heart attack or if you're going to have a major heart-related event, which I just found fascinating because before you really get into urology, you just think, well, you don't really understand the full complexity of it and why, you're like, oh, well, he just, is getting older. And you
Well,
don't really
yeah.
understand that it's so connected to the cardiovascular health.
Oh, absolutely. And I mean, if you take the penile artery as compared to the carotid artery, I think in diameter, let's say the penile artery is like 2 millimeters. That's my best guess. Don't quote me on that. And the carotid artery is like, 5 millimeters. There's a significant difference, right? And so
Mm-hmm.
whenever your guys are starting to have erectile dysfunction, that means half of that penile artery is already occluded, whether it be plaque or, again, cardiovascular disease. But if you're starting to have 50% occlusion in the penile arteries, imagine what it's doing to the carotids and everywhere else in the body. So it is a very, very early predictor of cardiovascular disease.
Yeah. Yeah. It really helps me change my practice too, to encourage, especially my younger guys who are getting it early on,
Yeah.
to get their cardiovascular work up and really start to take that seriously. Yeah. So you got a guy, he's coming in, he's tried Viagra and Cialis. He's like, man, like it gets me a little bit thicker, a little firmer, but I still can't penetrate. I'm not lasting until climax, whether I'm masturbating or with a partner. What are the next steps? What can you help them with?
So I believe the number one cause of erectile dysfunction is actually veno-occlusive dysfunction. So these guys can't get an erection, can't maintain it, which means, I'm trying to say it, the vasculature outside of the penis is not engorging enough to trap the blood inside the erection, so it actually leaks out. So if I do have one of those instances, I might recommend a constriction band, or in layman's terms, a cock ring.
Cock ring.
Yep. And then they're effective. They can be effective, but let's just say that doesn't work. Then obviously our next step is intracavernosal injections.
Yep.
And as providers, I mean, we're all familiar with it. It's called Trimix, combination of 3 different medications. One is alprostadil. Let's see, alprostadil. I write my little notes here. It's a prostaglandin. It's a vasodilator. It's smooth muscle relaxant. Then you have tepaverine, which is also a smooth muscle relaxant. And then the phentolamine, which is an alpha blocker. Of course, it relaxes the blood vessels.
Yeah.
What does that mean to the layperson? It's going to get you a boner.
Exactly.
Yeah.
Yep.
Yeah.
Yeah. I really I'm not sure how you guys do it in your office. I bring all the guys in and I do a demonstration with them. I give them an injection in the office so we can see how things go. And then the cool thing about Trimix is it's a titratable dose.
Yeah.
So I love that. I can give these guys an initial injection, a very low dose, because there's no having sex in our offices.
That you know of.
Well, I did have one guy try and finish one time, and I was like, can you stop?
Was that while you're examining him or after you're examining him?
Thank God it was while I was out of the room, and I came back in to say like, hey, how did it work? And it was all sticky, and it just was not.
The sheets were all ruffled.
Yeah, it was just not pleasant.
The bedside stand was knocked over.
On the door. Right, like, come on. But yeah, so we give them this low dose in the office, and then how do you tell your guys to titrate it at home?
Well, it's actually it's funny. I just wanted to mention it real quick. You know how I was saying, like the PD5 inhibitors, they're only responsive in like 60% of the population. ICI or Trimix or the intracavernosal injections, they're incredibly effective. But they're 80% effective. Yeah. So there's still a 20% chance of guys they don't know jack for.
Right.
And so it is unfortunate, but I run into that problem quite a bit.
Yeah.
But to answer your question, we bring guys in all the time, and I get so many inter-practice referrals. Obviously, we're the men's health clinic, we're the ED clinic, and I love it. I absolutely love it. I love being that gateway for all the physicians and providers in my practice for this kind of thing. So we get Trimix teaching all the time. So we actually, the way we do it now is we have a model. We've got a little penis in office. We call it Mr. Winky. And so, and so with Winky, my assistants, my medical staff, or my MAs will take Winky and syringes. Actually, and we have very detailed teaching sheet that we hand the patients and we let them read over it. And then my staff will go in there and actually do the injection teaching on the dummy, the model itself. We used to inject patients all the time. Yeah. But we started running into trouble where some of these guys were just incredibly sensitive to the Trimix. Yeah. And next thing you know, I'd end up with a priapism in office, and then I'd have to detumesce them with the phenylephrine. And then it would take like an original 15-minute slot, and it turned it to a 30, 45-minute slot, and it's a clinic killer. Right. And so we found that if we can start them, if we could just show them on a model and start them at, we usually tell them start at 0.1.
Yeah.
And then increase by 5 units, so 0.1, 0.15, 0.2, and all the way up. Now with trimix, if guys are getting up to 0.4, 4.5, really nothing's happened, I typically tell them, 50 units, 0.5 mLs is the max. If they're getting to that point, nothing's happening, it's time to come back in. We needed to, increase their dosage to either supermix or even explore other options.
Yeah.
That being said, let me take this time out to recognize my staff. I told you that I said, my MAs goes and they do all the teaching. My clinic and my patient satisfaction and where we are today would not be here without my staff. My staff never gets enough recognition. So shout out to my crew.
Yeah, that's awesome.
Yeah, my crew, we're like a well-oiled machine. We're like a good mullet,
Yeah.
You bring the patient in the front and it's all business, but once you get to the back, it's party time.
Party time. Absolutely. I love that. We still do injections, but I do the 0.1 to start them with. So I don't run into a lot of priapisms. Just because I start them really low. But I do always, my trimix appointments will always be before 10 a.m. just in case that happens. Even if they leave and they're fine, they can still come back during clinic hours then if something were to happen.
Yeah, it is rare. It is rare, but
yeah,
there are times where we will actually inject them, and it's okay.
Yeah, I think the biggest thing when I send guys home is making sure they go in far enough with the needle, because some of them get too timid with that.
Right.
And like you said, if you're getting too much, then let me know so we can order another dose or talk
Absolutely.
about it. Yeah.
And now I usually, and about that time, I discuss super mix. I know there are other mixtures out there. There's quad mix. There's other things. Honestly, once I get to the super mix, I start planting the seed of an implant. I don't dick around with any of the other stuff.
Right.
I mean, you're just kicking the can down the road.
Yeah.
And so
I agree. I'm the same way. I do have a couple guys who refuse to go the implant route and they're just keep kicking them up on doses of the trimix and super and quad and all of that.
Yeah.
I mean, you're not going to please everybody, and there are people who are just not going to do surgery. When you have patients who still have venous leak with the trimix, will you have them use a cock ring with the trimix?
Sometimes.
Yeah.
I don't. I mean, I'll recommend it every now and then. It certainly doesn't hurt. Again, it's the veno-occlusive dysfunction. In fact, I had a patient just earlier this morning. I had to explain it to him because he wasn't quite getting it.
Yeah.
And again, my dear mentor, Dr. Jones, love that guy. He explained it to me a long time ago. He said, imagine if you have like a plant pot, right? And that pot, you're filling that pot up with water, but it has a little bitty hole in the bottom. So that water is just leaking out of the pot, and slowly that water starts lowering out. But if you keep pouring water into the pot, it maintains that perfusion. It maintains that full pot. And so that's kind of the good thing about the trimix and these medications. They keep that perfusion in there. But again, sometimes the constriction band will help that if guys just can't get around that.
Yeah, absolutely. I just had a fleeting thought about trimix too. Doggone it.
Dadgummit.
No, I think, it's a great option. And a lot of guys, when you start talking about, oh, you're going to put a needle in your penis, they get scared.
Hey, sign me up. They're usually like, I'll take 2 of them. Well, if one is good, let's do 3.
Right. Why not? I've only had one guy tell me that it wasn't worth it, that we did the demonstration and he said, absolutely not. Everybody else is like, oh, it's not that big of a deal. I would say a vast majority of my patients really don't even feel it, especially if they have diabetic neuropathy to any degree. It's really not that big of a deal.
Yeah, I mean, that's funny you say that. I've had lots of guys who have quote unquote failed it. Yeah. They'll try it once and maybe twice, and what I always say, hey, I'll try anything 3 times.
Yeah.
But like sometimes they'll come, and so and then they'll come in, they're like, it's not for me, Scott. And I'm like, that's cool, whatever. Yeah. But funny story. I a little off topic. For whatever reason, I don't know if you have anything like this. I have a pretty strong swinger population. And so whenever they come in, those people just love to talk. They're like CrossFitters. They just want to tell you all their story and what they're doing. So whenever they come in, I'm like, oh, I just put my computer aside. I'm like, okay, well, what happened last week? And tell me more. But they're funny. They're so funny. And I've had some of the spouses come in, or girlfriends.
Yeah.
And they'll be like, oh yeah, we were at a party the other night and that guy had a trimix boner. You could just see him walking around the party like he owned the place. I'm like, a trimix boner. So it's very common out there in the swinger population. And
Yes,
so they use it very frequently.
absolutely. I have had guys come in specifically for that reason. Hey,
Uh-huh.
Viagra works fine when it's just me and my wife, but when we have these group sessions, I need to last
Mm-hmm.
longer and I want it for that. And okay, who am
Yeah,
I to judge? Go do your thing.
exactly. Just be careful of scar tissue
That's
forming.
right.
It
That's
might
right.
start to curve on you.
Yeah. I do love that about Trimix, though, is that you don't get the side effect profile that you get with Viagra and Cialis.
Well, yeah, I mean, it's incredibly safe, especially, for our cardiac patients.
Mm-hmm.
With the PD5s, you worry about hypotension and the cardiac side effects. And of course, some of these patients with strong cardiovascular disease, I lots of times will actually call their cardiologist and say, are you okay with me,
Mm-hmm.
starting them on these medications? But if there's some guys like history of CVA and that kind of stuff, I'm like, absolutely not. So like Trimix and ICI is actually the safest treatment
Yeah.
for my cardiovascular patients.
Yeah. I absolutely agree with that. Yep.
Yeah.
Yeah. So, all right. So a guy comes in, he's done the pills,
Uh-huh.
he's done the injections. He's
Uh-huh.
either just over the injections or they're not really doing it anymore. What's next?
What we call in San Antonio is the pompita, which it's the penile implant. And so we have several options. There's 3 different models. One is called a 3-piece. The other
Mhm.
one's an ambicor. The other one is a malleable, which we call the Tactra. I'm sure you're familiar with
Yep.
it. For the just the regular stranger out there listening, our go-to is called a 3-piece or an IPP, an inflatable penile prosthesis. And so what we do, the way I explain it to my patients, for lack of a better term, we have 2 cylinders, 2 silicone cylinders. We hollow out the inside of the penile erectile chambers, which is the corporal cavernosum.
Mhm.
We place a small pump inside the scrotum and a small reservoir inside the abdomen. I know it sounds like a lot. It really isn't. It's all internal. Yep. And whenever I explain it to my guys, if you're at the gym showering next to your buddy and
Mhm.
as most guys do, we tend to catch a glance of our neighbor over there just to make sure that we compare,
Uh-huh.
retrospectively, because guys and our penises,
That's right.
we're like, yeah,
I like that you so willingly admit that, though, because there's
oh,
guys who are going to pretend like they don't do that, and we
oh,
know
we
you
all
do.
we all do it. We all do it. Shoot, we're like, oh, well, okay, and then
Yeah, we do it too. We just don't have an appendage.
exactly, yeah. And so, anyways, if you're showering next to your buddy, nobody can tell that you have this
Yep.
implant. So, and that's so, and again, going back to the pills are 60% effective.
Mhm.
ICI is 80% effective. The penile implant is 100% effective.
Yep.
Obviously there's some stipulations, body habitus, link, mental, psych,
Mhm.
realistic expectations, all of that set aside. But if you got a good candidate, that implant, it's ready to go. Whenever you're
Yeah.
ready to go, it's ready to go.
For as long as you want to go.
Yeah, exactly. Let's just say, that goes back to your and Ken's podcast about ejaculation
Yep.
issues. Go all night, baby.
That's right.
But and I tell guys, let's just say that the Trimix or the injections work for you, right?
Yeah.
You can only inject 2, maybe 3 times a week max,
Yep.
right? That's all we recommend.
Yeah. Same.
With the implant, you can do it 3 times a day if you want.
Yep.
So it's a wonderful device. Our satisfaction rates are easily over 90%.
Yeah.
There's a newer model out there. I think you heard me speak about it at SMS and at our sex convention.
Yes.
Yeah. Yeah, it's from Boston Scientific. It is called the Tenaccio. It is a wonderful device.
Yeah.
It's incredibly easy to use. Our patients are having really, really good results with it. I have an incredible team in San Antonio. JT, oh gosh, Karina, I could just name names, but yeah, Boston Scientific, they're just wonderful. But the Tenaccio is just a wonderful device. And so that's really kind of our go-to.
Yeah, I agree with the Tenaccio. It's,
Mhm.
I hadn't gotten a chance to use it, to play with it, if you will, prior to SMS.
Oh, you're missing out.
I know, but now I have. So Dr. Goldfarb and Dr. Fennig, who are my 2 implanters, they have both used it now. And I'm telling you, teaching these guys, It's so much easier than the older pump,
Yep.
and we had a replacement, right? And so that guy had the
Hmm.
older Boston and got a newer Boston, and the Tenaccio far and above. He just loved it. It gets them harder, faster, easier to feel. The release is easier. It's just
It's
amazing.
just like the bionic man. We can
That's
make him
right.
stronger, faster,
Yes.
harder.
Yes. Just call it Captain America.
Steve Rogers, actually, but good
There we go.
try.
Yeah, yeah, for
I'm so
sure.
sorry, Steve Austin. Steve Austin, that's
Yes.
the bionic man. Sorry. But anyways, yeah. So that's that's kind of the standard of care as far as implants.
Yeah.
And, then we do have the older patients who don't have the greatest dexterity,
Yeah.
and so we use the malleable device.
Hmm.
Our older malleable devices, you may remember, they were actually metal,
Yeah.
and they were just two rods that you would stick in the penis and the
Hmm.
cavernosum. And whenever it was go time, you just bend it up.
Yep.
Whenever it's not go time, you bend it down and out of the way. Well, these metal. I mean, I actually had one couple come in one time, and this will eventually lead into our next section, which is Peyronie's. I had this one couple one time. They're a little older.
Hmm.
They were so aggressive with their intercourse that they actually broke that metal malleable.
Oh my goodness.
I mean, these people like to party.
I guess so.
So, but funny enough, we actually replaced him with a three-piece. But like our
Yeah.
newer malleable, of course, is called the Tactra. There's no
Yes.
metal. It's a very different device. But yeah, it's better for the older guys who have just terrible dexterity, but
Yeah.
want to remain sexually active.
Yeah, I agree. For the listeners who aren't really familiar with it, just think of like a thick pipe cleaner. You can bend it the way that you want to bend it.
Right.
There's nothing really else to it other than that. So yeah, we agree. And then, we'll get into it with the Peyronie's too, but my docs will use that as a placeholder
Mm-hmm.
as well
Right.
for guys who have priapism and need to wait until they get their three-piece.
Oh, absolutely. It's a cavernosal savage. You want to keep those
Yep.
tissues open, otherwise you'll get that tissue ischemia. They'll lose penile length, and it's
Yep.
much more difficult to get anything in after that. But
Yeah.
that being said, infection rate for those implants is incredibly low.
Yeah.
We implant diabetics all the time.
Yeah.
In non-diabetics, our infection rate is less than 1%. And
Awesome.
in our diabetic population, so it's less than 2 to 3%. So still very low. Nothing's
Yeah, that's
perfect,
awesome.
unfortunately. It is surgery.
Right.
Yeah,
Yep.
but it's
Yeah.
wonderful.
That's awesome. Yeah, I absolutely love the patients that get them. They're happy, their spouse is happy. A lot of times we'll see them in our post-prostatectomy patients who unfortunately had nerve damage and didn't get their erections back.
Well, and that's funny that you mentioned that, because you asked me earlier about the whole ED process, and I
Yeah.
said it's an incredibly open-ended question.
Yeah.
I do a lot of penile rehab on
Mm.
post-prostatectomy patients.
Yeah.
And of course, those prostatectomy patients, their ED is a condition called neuropraxia. It's nerve damage.
Yep.
And I don't care how good the surgeon is, and Urology San Antonio has some amazing surgeons. So shout out
Yeah.
Dr. Wyatt, shout out Dr. Stallman. They're wonderful. But you go in there and you start pushing those nerves out of the way to get to that prostate. Mr. Happy just takes a big hit and it just kind of
Yep.
contracts in. And it goes into a state of shock. And so it
Yeah.
just doesn't really know what to do with itself. So I do a lot of penile rehab with these guys.
Yep.
The majority of the time, with time, I can get quite a bit of erectile function
Yeah.
back. But there's a lot of these guys that do lead to penile implants.
Yeah.
And that, funny enough, that being said, Ken Mitchell, who I was talking about earlier, love that guy. He, about 11 years ago, he's the one, he helped me get like my penile rehab up and running.
Yeah.
So I did some training with him. So again, I don't even know why you have me on this podcast. You just need to talk to Ken all the time.
Well, I can't get him every week. He's a busy man.
He's a busy man. APP of the year.
That's
what
right.
have you.
That's right. He's going to listen to this and get annoyed.
Yeah.
No, and the other thing with the with erectile dysfunction, just in general, that we really didn't talk about yet is the psychological side of it. So I always tell my guys, your head-to-head connection, big to little guy, it's very strong.
No.
And if you've got a lot going on up here, whether it's you didn't get an erection last time, so you're worried about getting one this time, you are with your girlfriend, not your wife. I've heard that story many times.
I was just gonna say that.
Yeah.
Years ago, way before we even kind of started researching erectile dysfunction and what have you, guys would go in and talk to the doctor about this. Oh, it's all in your head.
Yeah.
It's all in your head. I find that rarely is the case. Now, that being said, it does happen every now and then. I can't tell you how many times I'm like, oh yeah, my girlfriend, it's wonderful. Sex is amazing. But my
Yeah.
wife, I just can't perform. I can't get an erection. I'm like,
Right.
well,
Yep.
I'm not a miracle worker, my
Right.
friend, but
Yeah.
let's see
Here's
what
a
we can do.
therapist for you.
Right. Yeah. Yeah. No judges, but let's see what we
Right.
can do.
Right.
Yeah. So
Yeah.
there can absolutely be a psychological component.
Yeah. I definitely see the psychological component more in younger guys.
Mm-hmm.
Guys coming in their 20s who are having issues with erections. They are generally athletes or in college, in stressful programs, starting a new career, those kinds of things, that their life is just so stressful and they are all over the place mentally because of that, that they just lose that ability.
Well, in this generation, my staff and I laugh about it all the time. This generation doesn't know how to cope, and
Right.
that's the old fogey in me. Like,
Yeah.
they just don't know how to cope. Things are just so different. A lot of those
Yeah.
kids, though, same thing. You start investigating a little bit more. They masturbate all the time.
Mm-hmm.
Sometimes a couple times a day. Which,
Right.
hey, party
And they're
time, right?
watching,
But yeah,
right.
and
And they're
porn.
watching a specific type of porn that doesn't
Exactly.
correlate to the type of sex that they're having.
Exactly. So then,
Yeah.
whenever they're with a female, it's just nothing works. And so
Right.
again, there's a huge psychological component.
Yeah. Yeah.
Thankfully, I have a wonderful sex therapist. Her name is Austin Siegler. She's in San
Okay.
Antonio, and I refer lots of patients to her. So
Yeah. Yeah.
and
I do a
so
lot of sex referrals, as therapy referrals as well.
I bet you do with those sex referrals.
Yes. Yes. So, we've talked all through this ED. One of the big issues that can cause ED and can cause, it's its own issue as well, is Peyronie's disease,
Correct.
curvature.
Correct.
So talk to me about that. What are you seeing in clinic with that? How are you diagnosing? What's going on with that?
All right, so for the layman who out there who doesn't really know what Peyronie's disease, so Peyronie's disease is a formation of scar tissue in the erection chambers, the corporal cavernosum. So that alone can cause erectile dysfunction by itself. You don't get good adequate blood flow. You don't get good stretching of the tissues. It can cause tissue ischemia. So it's a really nasty little disease process to treat in and of itself. Whenever I get whenever I get a patient who comes in, let's just say like a general ED consult, like I said, after taking a nice H&P and kind of trying to figuring out my plan, I can't tell you how many times I'll be like, oh, by the way, it kind of curves a little bit to this way. I'm like, okay, well, now you're leading me down a different path.
Yep.
And so let's just start with Peyronie's in general. So Peyronie's in general is usually defined in clinic, whenever I hear it, main complaint is painful erections and a curvature.
Yeah.
So painful erections, why? Well, because you're having that scar tissue formation that's building up within the penile tissue. So again, you don't get good stretch, you don't get good perfusion, it's tissue ischemia. And so they don't get the greatest erections. And so that being said, whenever I get these painful erections, I want to know a time frame. When did this start? How are your erections? I'm sorry, I keep messing with my earbud. It keeps falling out. How are your erections? So I just try to establish a nice erectile baseline function. So let's just say I have a new Peyronie's consult. So let's just, ED aside, let's just say new patient, Peyronie's consult. Main complaint, I'm like, okay, what's going on? Well, I've got this curvature. When did it start? Oh, it started about 3-4 months ago.
Yep.
Okay. How are your erections? Oh, they're good. They're wonderful. I still get great erections. Can you have intercourse? Yes, I can have intercourse, or no, I can't have intercourse. Does your partner complain? Yes or no? So those are like baseline questions.
Right.
And then I'm like, like a typical pervert. Hey, you got a picture of your penis?
Yep.
You got a picture of this curvature?
Let me see your dick pic.
This
is a solicited dick pic.
Yeah, exactly. I'm like, hey, bro, no, no judges. We got a picture.
Yep.
But it's all like, and like lots of times it will. I'm like, okay, that's a good picture. So I can establish the curvature, anywhere from 30, 40, 50 degrees, just whether it's up, left, right, up, down, all around. But, and so that's like my typical Peyronie's patient. So first things first, I'm like, how are your erections? Well, they're good. Wonderful. Are you taking anything? No. All right, I'm going to start you on something. Well, why? I don't need it. Well, my erections are fine. I'm trying to protect your penile tissue. I'm trying to enhance perfusion. So I typically start them on a daily Cialis. Daily versus PRN. I'm not a big fan of taking a medicine every day that you don't need to take. So if you take something PRN versus daily, I'm all for the PRN.
Yeah.
But I usually start them on the daily because it increases perfusion, especially at nighttime whenever they have those nocturnal erections. It just
Yeah.
keeps those penile tissues nice and healthy. So we want to preserve that erectile function.
Yeah.
The other thing I established is, are you able to have intercourse?
Mm-hmm.
Yes. If you are able to, is it interfering with y'all? They're like, well, no. I'm like, leave it alone. Don't
Yep.
jack with it. Leave it alone. It's
Yep.
fine. Are you able to have intercourse? No, we're not. Okay, why? It's too uncomfortable for my spouse or my partner. I'm like, okay.
Yep.
So that's when we start heading down that Peyronie's pathway.
Yeah.
And so again, so with Peyronie's, there's an acute phase and a chronic phase. The acute
Mm-hmm.
phase, this was what I was taught by my mentor. If you look at some of the literature out there, whether it's WebMD or some of those other places, their timelines vary. You
Mm-hmm.
might see anywhere from like 5 to 18 months as being the acute phase. What I
Right.
was taught was from the time you notice it up to about 12 months, a year.
Yeah.
Maybe at the earliest until they stabilize, I say maybe 8 to 10 months. That's whenever I maybe start
Yeah.
to intervene. So that's the acute phase. So whenever I tell patients, all right, you're in the acute phase from the time you noticed it, technically things at this point can possibly get worse. Your pain
Yeah.
can get worse, your curvature can get worse. If we get too aggressive, we can possibly make
Mm-hmm.
things worse. So I always start them on pentoxifylline. Pentoxifylline, funny enough, again, if you look at a lot of the literature out there, there's not a lot of places that actually support the use of it.
Okay.
But again, pentoxifylline, the way I was taught, it's an anti-inflammatory. It was originally used for intermittent claudication. It's a cardiac medication. It's theorized to have anti-inflammatory and anti-fibrogenic effects. So it increases blood flow. So it's theorized for the patient to help kind of stop or halt the progression of Peyronie's in its progress. That's what I tell patients.
Yeah.
So it stops the progression of the scar formation. And it's funny enough because with Peyronie's, whenever I started, years back, Peyronie's was always about plaque, plaque, plaque. You have the
Mm-hmm.
plaque. As the years have gone on, I've noticed that the vernacular has actually changed from plaque to scar to
Yeah.
scar tissues. They don't really use that plaque.
Yeah.
And so I start them on the pentoxifylline. Some people will use L-arginine. Some people will have their other cocktails. I just really kind of stick with the PD5 and the pentoxifylline.
Yeah.
And I tell guys that this is not a fix. Now,
Mm-hmm.
it is rare, but I have seen it where the Pentox will actually, it'll actually straighten them out over time.
Cool.
And they actually, it actually fixes the curvature.
That's awesome.
I don't see it a lot, but it does happen. Yeah. But if I can get them into like the chronic phase, which I typically say is, maybe 10 to 12 months from the time they notice the curvature, if I can get them to the chronic phase, then it's time to act.
Yeah.
Again, if you look at some of the literature out there, a lot of these places, or a lot of these like websites will tell you, during the acute phase, you can use intralesional injections, you can use traction devices, you can use all this other stuff. I don't do that.
Yeah.
I'm always scared that, again, you can make things worse. I don't want to get too aggressive during the acute phase. So I really try to just, enhance perfusion with the PD5, start the Pentox, and just kind of watch and wait.
Yeah,
now
that's my practice as well.
Yeah.
It's more of a watch and wait. I haven't done the Pentox. I'm going to have to incorporate that, but I've always done the daily Cialis.
Yeah, pentoxifylline, it's almost, and so of course, the SMSNA, if you listen to all those gurus, they all use pentoxifylline as well.
Yeah.
And so, it is rare, but I have seen it actually fix curvatures, and it's a nice surprise whenever it happens.
Yeah, well, and it's worth a try because it's, it's safe, and the alternative is once we get into the chronic phase, now we're doing injections or surgery.
Right, and it's very rare that patients can't tolerate it. I don't usually like side effects if they can't tolerate it is nausea, vomiting, gastro, upset, that kind of thing. But and that's why it's crucial. When I tell these guys, I need to know when you notice this curvature 3, 4, 6 months ago, and I have to go off of what they're saying.
Right.
But once I get them into the chronic phase, then I have kind of two options. Excuse me. Option number one, of course, is Xiaflex. As providers, we all know about Xiaflex. Xiaflex is a collagenase. It is the only FDA-approved treatment for Xiaflex. And I can't say it enough, the only FDA-approved. It's by Endo. Again, I have a wonderful Endo team. Shout out Dawn and Megan. They were just in my office this morning. They're wonderful.
Yeah, but I have Linda. I love her.
Yeah, well, I love Lamp. So that's a dumb movie reference. I forgot to mention in my bio, I'm fluent in movie quotes too.
Excellent. Love
Yeah.
it. Yeah.
So, but anyways, it's the only FDA approved treatment for
Peyronie's.
Peyronie's. Yes,
Yeah.
thank you. It's an intralesional injection. Like I said, it's a collagenase that you can actually inject into the scar tissue to actually disrupt it and break it up and hopefully start to kind of straighten some of these guys out. I always tell my patients, you know, it's very rare that I'm going to get you completely straight. I have had it happen sometimes, and whenever it does happen, I walk around in my office like a peacock,
Right.
and with my chest puffed out, I'm like, "Who the man?"
Yes.
I'm the man, because that's what my mama tells me. And then so that's, of course, that's Xiaflex. We used to use, I say we, urologists used to use verapamil, interleukin, or I'm saying that wrong. You know, all these other weird treatments, and none of that stuff really works. Nobody really uses it anymore.
Yeah.
And of course, the other option is surgery, penile plication. Again, you know, a lot of the literature out there says you don't do surgery until the chronic phase.
Right.
Most of my surgeons, they'll like, if you come in and you're brand new Peyronie's patients, we're like, all right, here's your options. We can do surgery now, or we can wait a little bit, wait for it to stabilize and do injections. And these guys will say, I want surgery. Boom, you take them to surgery that next day.
Yeah.
And so we can straighten you out overnight.
Right.
Now, obviously, with application, depending on how significant the curvature is, you know, I always tell patients, you know, if you have a curvature like this, we can't just straighten you out like that. We have to pull you down and straight.
Right.
And so, you know, there's always the risk for loss of length. And whenever you tell a guy, hey, your wiener might be a little bit shorter, we're like, whoa. You know, we're very wiener centric around in the U.S.
You don't say.
Yeah.
Yeah, I think, you know, that's one of the things that I always, you know, talk to the guys about too is, you know, that can happen with the loss of length with the surgery. But if you're not having sex at all because your curvature is so bad that it's hurting your partner, or you don't get any positions that you can get it in, then why not lose a little length, but then you're going to be able to have sex again.
Oh, and some of these guys, they're so penocentric. I can pick these guys out. Of course, I've been doing it long enough. As soon as they come in, and if they start going after length, I like, you know, my blockade goes up, my walls go up, and I'm just very, very much like, you know what? I may not be able to help you. You know, I may have to refer you elsewhere because the realistic expectations are just not there.
Right.
And no matter, you can tell them 10, 20, 30 times, but they're not going to hear it. They're only going to hear and see what they want to. So that's the other part of it, is setting realistic expectations.
Agreed. Yeah.
So, but anyway, so that's for the guy who actually has good erectile function and Peyronie's disease.
Yeah.
So for the guys, let's just say I have a guy who comes in, hey, new Peyronie's consult. Hey, okay, well, how are your erections? Lousy. Are you taking anything? Yeah, Viagra, Cialis. Do they do anything? Not a thing. I'm like, okay. So I start trying to, you know, set them up for. I start pitching the idea of a penile implant, because the penile implant is going to correct both problems, to correct curvature and erectile dysfunction.
Yes.
And so, same thing, kind of like what we talked about earlier. You slide those two cylinders inside the penis. Lots of times, the implant itself will correct the curvature. Now, lots of times, it's just not enough, and the surgeon may have to do a plication in conjunction with the penile implant. So it's kind of a combo procedure. But yeah, it kind of takes two birds on one stone.
Yeah, no, and I think that's great. And I love that we talked about both ED and Peyronie's today, because Peyronie's does go hand in hand with ED so much of the time, whether it's first or second in that, you know, roadmap or highway, I guess. But yeah, I think, you know, all these topics or all these ideas that you've given us are fantastic today. And I really, really appreciate you coming on here and talking through this with me.
Absolutely.
Yeah,
it's my pleasure.
Awesome. So I will, in the show notes, put a link to the Men's Health Clinic where
Urology
Scott works. Yep, absolutely. So anybody down in that area can get a good appointment with a fantastic nurse practitioner.
The best.
Who I personally would recommend, although I don't have a penis, but, you know, I would send men to you.
You'd be a lot cooler if you did. Penises are wonderful. You know, it always makes me wonder, too, what's the plural of penis? Is it peni or penises? You know? I guess I need to ask my mom. She's an English teacher, so she'd probably
get back to us on that. Yeah. Fantastic. Well, thank you so much, Scott, and everybody. Thanks for listening. We will see you next time on Between the Sheets.
Thanks again. Bye-bye.
Thank you for listening and spending time with me today. You can catch new episodes of Between the Sheets every Wednesday, because what better way to add some spice to your life than to have a new podcast on Hump Day? We will continue to explore common, uncommon, and taboo topics related to sexual health and wellness. Please send any comments, questions, or stories to podcastbetweenthesheets@gmail.com. That's all one word, podcastbetweenthesheets@gmail.com. Have a great day. And remember how important it is to discuss these topics with your friends, your family, and of course your partners. In fact, you can like, follow, and share this podcast so they can see it too. See you next time for more sexual health topics between the sheets.